Every second counts during a cardiac arrest. Rhythms change quickly, and different treatments are frequently required. The ZOLL PD multifunction pacing defibrillation electrodes and cable are a single comprehensive cardiac resuscitation system providing immediate rhythm diagnosis, hands-off defibrillation, and non-invasive pacing. Alternating defibrillation, synchronized cardioversion, and pacing are as quickly accomplished as moving the PD selector switch from one area to another. As a code evolves, each rhythm may be treated quickly and safely with a multifunction cable and electrodes. Installing the cable. Remove defibrillator panel assembly. Simultaneously depress indentations on either side of the connector and pull straight upward. Insert the multifunction cable in the machine in the same manner. The cable is locked in place when a snap is heard. Apply electrodes to patient. Remove protective adhesive cover from the electrodes and apply round front electrode in the V2 to V4 position and rectangular back electrode to the left of the spine just below the scapula. To ensure proper gel coupling, you should first secure the adhesive to the skin by firmly running your finger around the periphery of the electrode, and then press the center gently. If the patient has excessive chest hair, it may be clipped. However, shaving is contraindicated. Slight positioning changes may be made without compromise in function. The anterolateral electrode position may be used for defibrillation, but will necessitate significantly higher pacing thresholds. Connect the electrodes to the MFE cable. To turn the ZOLL PD on, simply select the function on the rotary power switch. The monitor, defibrillator, or the pacer are immediately available and may be changed at any time to properly treat the patient's rhythms. The initial lead source is through the multifunction electrodes in the monitor or defibrillation mode. You will visualize a modified lead 2 tracing. 3 standard sensing electrodes in right arm, left arm, and the left leg position connected to the ECG cable will additionally provide monitoring leads 1, 2, and 3. In the pacing mode, only leads 1, 2, and 3 are accessible. Standard electrodes need to be applied to observe and sense pacing on the monitor screen. Multifunction electrodes will pace either synchronously or asynchronously depending on the application of the 3 sensing electrodes. Defibrillation. Defibrillation function is 1, 2, 3. First, select energy on the rotary dial. Settings from 2 to 360 joules are available. Second, push the charge indicator. The PD1200 will charge within 5 to 8 seconds. You will observe the charge indicator light on top of the MFE cable control as well as the joules indication on the monitor screen. The charge is held for 60 seconds with the tone changing after 50 seconds to indicate the pending loss of the charge. Third, discharge defibrillator by simultaneously depressing the 2 orange buttons at the cable connector, holding in briefly. Warning: personnel should be warned to stand clear of the patient in advance of defibrillation. Warning: an electrodes off message will appear on the PD1200 monitor screen if all connections are not intact and the device will not discharge. However, the charge is maintained to allow the operator to correct the condition. Synchronized cardioversion. To perform synchronized cardioversion, first press the sync button in the monitor on position. Sync monitor will appear on the screen. A sync marker or intensified dot will appear on each R wave as well as a mark above the waveform on the ECG recorder strip. When desired synchronization is observed, select energy and press charge. Stand clear and simultaneously depress and hold both discharge buttons. The defibrillator will discharge when the next R wave is sensed. If additional counter shocks are required, sync must be selected with each cardioversion. Energy level should be selected for subsequent shocks according to ACLS protocol for presenting rhythm. Note that the use of the multifunction electrodes alone provide only one ECG lead. Standard ECG leads provide the choice of an additional 3 monitoring leads. While signal quality of MFE may be comparable to standard ECG leads, muscle tremors following discharge may produce noise and resultant artifact. To test the PD-1200 defibrillator capacity, insert the end of the multifunction cable in the receptacle at the left front of the device. Choose the 200 joule setting, charge and discharge into the machine by simultaneously depressing both buttons on the cable. The Test OK message will appear on the screen, and a 15-second ECG strip will print out. Caution: do not leave the multifunction cable in the test port when not in use. Pacing. The ZOLL PD non-invasive pacemaker is a VVI demand pacer. Asynchronous pacing will be achieved when using multifunction electrodes without sensing leads. Select pacer on position with rate ppm and output MA at the lowest level. Set a pacing rate of 10 to 20 beats higher than the patient's intrinsic rate. If no intrinsic rate exists, use 60 ppm. Observe the pacing artifact, a wide downward deflected marker, and verify that it falls in diastole if the patient has a heart rate. Average pacing thresholds are 55 to 65 MA. Increase output MA slowly until stimulation is effective, at which point the intrinsic QRS complexes will be suppressed. Pace rhythm is characterized by a widened negative QRS with a large T wave. The negative pacing artifact immediately precedes each complex. You will also observe chest muscle movement in most patients when pacing. Adjust MA upward 10% to assure continued capture. Standby pacing may be advisable in certain patients. In this mode, the ZOLL PD will automatically provide a pacing stimulus whenever the patient's heart drops beneath a set level. To achieve this, after initial capture, set the pace rate below the patient's heart rate. Pacing will be suppressed unless the patient's heart rate drops below the set rate. The 4-to-1 test mode may be used to assess the intrinsic rate. When depressed and held in, the 4-to-1 switch delivers a pacing impulse approximately every 4th pace beat. This may also be utilized when prophylactically determining capture threshold in a conscious, alert patient. Warning: MFE electrodes should not be used for continuous pacing longer than 8 hours. You have observed how it is quickly possible to alternate therapy with the ZOLL PD 1200. As rhythms change, you may defibrillate, cardiovert, or pace. Operation is fast, effective, and safe for both patient and clinicians. The ZOLL PD multifunction electrodes save time, resources, and lives.
Cardiac arrest is an emergency situation demanding immediate response and application of advanced life support. The course of cardiac arrest is unpredictable, requiring defibrillation and sometimes non-invasive temporary pacing. Frequently, both are needed in rapid succession, such as during post-shock asystole. The ZOLL PD 1200 pacemaker defibrillator provides both defibrillation and non-invasive temporary pacing in a single integrated unit. The PD is a complete cardiac resuscitation system that includes the clinically proven ZOLL non-invasive temporary pacemaker for bradiasystolic arrest, impending arrests, heart blocks, and many other applications. The PD is also an advanced technology defibrillator for cardiac arrests requiring immediate defibrillation and provides synchronized cardioversion for malignant arrhythmias refractory to drugs. Lightweight, portable, and powered by an onboard battery or line current, the ZOLL PD can be used anywhere in the hospital, even during patient transport. Simple, straightforward operation is paramount to all cardiac resuscitation equipment. The focus of the ZOLL PD operation is the rotary selector switch, easily located at the center of the instrument, just below the monitor. This control allows selection of all three operating modes. Defibrillator on, with various energy selections. Pacer on. Monitor on. It also turns the power off. Defibrillator charge controls are located on the front panel or on the apex paddles. Either control will charge the defibrillator. Defibrillator discharge controls are located both on the apex and sternum paddles. Both paddle discharge controls must be pressed at the same time to discharge the defibrillator. When non-invasive pacing has been selected, the pacing rate and output controls are located on the right side of the monitor and are color-coded green for easy identification. The high-resolution monitor displays the current instrument mode, as well as heart rate, lead selected, ECG size, and heart rate alarm activation. The strip chart recorder provides a hard copy of the ECG and additional information such as time, date, ECG lead, size, and heart rate. Defibrillation energy is printed each time the defibrillator is discharged. The recorder can be started manually and automatically during an alarm or defibrillator discharge. A clear and concise operating card is located on top to provide the operational essentials for defibrillation and pacing. The following case study illustrates the many applications and simple operation of the ZOLL PD. A 58-year-old man with no prior history of coronary heart disease entered the emergency room with severe chest pain radiating to his left arm. He was diaphoretic, confused, and had a regular pulse of 40 and a blood pressure of 90/50. The bradycardia was treated with atropine, and non-invasive pacing electrodes were applied. Bradycardia continued, and non-invasive pacing was started. The patient was stabilized with normal sinus rhythm restored within an hour. The patient was moved to the CCU. Within 2 hours, he developed atrial flutter with a ventricular rate of 90 and rapidly worsening chest pain. Synchronized cardioversion was performed, restoring normal sinus rhythm. Within an hour, ventricular tachycardia appeared, with rapid deterioration to ventricular fibrillation. The patient was then defibrillated at 200 joules and returned to normal sinus rhythm. Bradycardia of 28 beats per minute then developed, and the patient was successfully treated with non-invasive pacing. He was paced intermittently for the next 4 hours and was eventually moved to the cath lab for implantation of a permanent pacer. Non-invasive temporary pacing provides emergency cardiac stimulation for asystole, bradycardia, AV heart block, or to maintain ventricular rhythm. It is now an established part of advanced cardiac life support and is included in ACLS protocols for bradycardia and asystole. In addition to use in cardiac resuscitation, NTP should also be employed for reflex vagal or drug-induced standstill, cardioactive drug toxicity including digoxin, verapamil, quinidine, lidocaine, or beta blockers. NTP can also be used effectively to suppress ventricular ectopy or overdrive VT and SVT less than 150 beats per minute. NTP can also be employed prophylactically in standby readiness for any patient at risk of arrest or symptomatic bradyarrhythmias. The significant risk of reperfusion arrhythmias during thrombolytic therapy may require use of non-invasive temporary pacing. It should also be pointed out that while NTP is often used to buy time so that a temporary endocardial wire can be placed more conveniently, there are times when placement of an endocardial pacing wire may be contraindicated, such as during thrombolytic therapy or where the risks cannot be justified. Non-invasive pacing is quickly established. ECG leads are applied and connected to the PD. The PD is turned to the monitor on position, and the pacemaker output is set to 0 milliamps. Apply the back electrode between the scapula and spine at the heart level. The front electrode should be applied to the precordial area beneath the left nipple or beneath the breast on female patients. Connect the pacer cables to the PD. Select Pacer On. Set pacing rate 10 to 20 beats per minute faster than the patient's intrinsic rate. If no intrinsic rate exists, use 60 beats per minute. Observe the pacing artifact and see that it is well positioned in diastole. Increase the milliamp output until stimulation is effective. A captured ventricular response is normally characterized by suppression of the intrinsic QRS complex. The widened QRS resembles an ectopic beat. This trace shows effective capture. Note the wide R wave, negative T waves, and absence of P waves. Changing leads can be helpful in determining capture. The shape and size of pacing waveforms will vary depending on lead chosen, and variation from patient to patient can be expected. The ideal output current is the lowest value that will maintain capture. This is usually about 10% above threshold. For certain patients at risk of developing symptomatic bradycardia, it will be advisable to use the ZOLL PD in standby. When used in standby mode, the PD will automatically provide a pacing stimulus whenever the patient's heart rate drops below a predetermined level. To use the ZOLL PD in standby mode, first establish effective pacing. Note the milliamps and run an ECG strip to document morphology at capture. Set milliamps 10% higher than capture. Turn the pacing rate to below the patient's heart rate. This will suppress pacing unless the patient's own rate drops below the set pacing rate. Several aspects of non-invasive pacing should be understood by users of the ZOLL PD. It is important to recognize capture. The normal range for capture is between 40 and 80 milliamps, but some patients may require higher outputs. While most patients will tolerate non-invasive pacing, some patients may require sedation or discontinuance. On most patients, the skeletal muscle will begin to contract as the output is increased. This is normal. Absence of skeletal muscle contraction, however, does not necessarily mean the pacer is not working properly. Anesthesia, drugs, and prolonged hypoxemia may minimize skeletal muscle contraction. Do not shave the skin prior to electrode application. Even small nicks could cause excessive pain. Excess hair may be trimmed with scissors. Pediatric patients may also be paced by using smaller, specially designed electrodes. Defibrillation must be accomplished very quickly in an emergency. First, select energy to the desired level. This action automatically turns the power on and selects paddles as the source for the ECG. Apply electrode gel to both paddles. Rubbing the paddles together will spread the gel evenly. Press paddles firmly to the patient's chest. The one labeled sternum is applied to the right of the sternum, just below the clavicle. The apex paddle should be placed just below and to the left of the left nipple on the anterior axillary line. Observe the rhythm on the monitor. If defibrillation is indicated, charge the defibrillator by pressing the charge button on the apex paddle or the front panel. Do this just before you're ready to discharge the paddles. When charging is complete, the charge indicator lamp will light and an audible tone will sound. Warn attending personnel to stand clear. Discharge the defibrillator by depressing the buttons on both paddles simultaneously. After discharge, be sure to clean away electrode gel from both the defibrillator paddles and the patient to prevent gel bridge formation between the paddles. For pediatric patients, slide off the adult paddles to expose the built-in pediatric paddles. For certain arrhythmias, such as VTAC or atrial flutter, synchronized cardioversion is indicated. Connect the ECG leads to the patient and the PD. You cannot use paddles for the ECG source when performing synchronized cardioversion. Select Monitor On. Press the Sync button on the front panel. Verify the R wave is being marked on each beat. This appears as an intensified dot or dash on the monitor. If necessary, change leads and ECG size to select the best ECG display. Select the desired energy. Observe the sync message on the screen when energy is selected. Press the Charge button. Press the Discharge button on both paddles simultaneously. The defibrillator will discharge on the next R wave. Should you need to disarm the defibrillator after it has been charged, turn the selector switch to Monitor On or any other position. This will discharge the defibrillator internally. If a new energy is selected after charging is complete, you must press Charge to rearm the defibrillator. If the defibrillator is not discharged within 60 seconds after being charged, it will automatically discharge the energy internally. 10 seconds prior to this auto discharge, the charge ready tone will beep intermittently. A paddle fault message will appear whenever the paddles are not seated in their connector properly. A complete test of the defibrillator should be performed routinely. With the paddles securely in place within their holders, charge the unit to 200 joules. Firmly grasp the handles using the thumbs to actuate the controls. Take care not to touch the metal edge of the paddles. Discharge the defibrillator. A Test OK message appears on the monitor and recorder strip indicating proper operation. Only skilled personnel should attempt defibrillation. Do not touch bed, patient, or equipment during defibrillation. Warn all attending personnel to stand clear of patient and bed prior to discharge. Wipe off excess gel from patient and paddles after each discharge. The monitor on the ZOLL PD can be used for either short-term or long-term cardiac monitoring. For patient transport applications, the onboard battery supply provides up to 2 hours of continuous monitoring. A low battery message will appear when there is about 20 minutes of monitoring remaining, or 5 360 joules discharges. Press the lead button to select the desired ECG lead and adjust the ECG size until the desired waveform size is displayed. Should an ECG lead off message appear, inspect the leads, wires, and cables. Adjust the R-wave beeper volume, and if desired, activate the heart rate alarms. Alarm limits can be changed by adjusting the upper and lower alarm rates. Please refer to the operator's manual for details. A freeze function allows a momentary freezing of the monitor display. The built-in recorder will document the ECG trace with a 4-second delay at all times. The recorder can be controlled manually with the Start-Stop button and functions automatically when alarm rates are violated or when the defibrillator has been discharged. Pressing the Mark button will create a distinctive mark on the trace for later correlation with an event. Included on the ECG strip is time, date, ECG lead size, heart rate, and pacing output in milliamps. For defibrillation, delivered energy will also be printed. To reload paper, insert the new roll on the spool grid side down. Start the recorder and insert the paper into the bottom slot until it begins to pull through. The ZOLL PD represents an important contribution to advanced cardiac life support. The PD combines the proven technology of the ZOLL non-invasive temporary pacemaker with an advanced technology defibrillator and monitor providing emergency and critical care personnel with an integrated and complete cardiac resuscitation system. Portable and battery-operated, the PD can be used throughout the hospital and belongs wherever ordinary defibrillators are now being used. For additional information on the PD 1200, contact your local ZMI representative.